So what is the problem? So here's the 34-year-old female. This is her medial side. You can put the probe all the way to the back of the knee, so clearly the entire medial meniscus is gone. Here's a lateral-sided male, offensive lineman, meniscectomy, valgus alignment, pain laterally. I think Nick mentioned that in his talk. The alignment, a valgus knee, prior lateral meniscectomy. Ooh, that's a patient that likes to rear its ugly head at a very, very young age, so be very, very careful. So what do we hope to do by replacing the meniscus? Obviously replace the function of the menisci. Usually these patients have pain. I think probably what we don't do enough of, and what has a role, particularly if you are a ligament surgeon, is the stability on the lateral side. If you have a posterolateral corner injury and you're missing any of your lateral meniscus, that knee is going to be more unstable. Particularly in the ACL deficient knee, we know that medial meniscus is the most important secondary stabilizer, so the same applies. Any part of that medial meniscus that you got to take out is going to place more load on your ACL graft, so you need to remember that. I think probably in 17 years of practice in doing this operation, I think like for many operations we do, who we select to operate on is critical to our outcomes. I change this slide every year because this is my age. I consider myself young. I'm 48, so you should only do this on young patients. We're not at the point yet where I think we're operating on asymptomatic patients, although instability cases can be unique for that. We don't like to do grade 3 and above or bipolar changes. They must have stability in their knee and normal alignment. These are often complex patients. I think the MRI is very helpful in evaluating these patients. Often these patients will come to you with 1 or 2 MRIs. They've had x-rays. I think often they do not come to see me with an alignment film. I think this is very, very important. If you place a meniscus in a malaligned knee, it's probably going to fail. We don't want to do a meniscal allograft or an arthroscopy for that example on this patient. I can't tell you how many patients I see, or probably how many of you see in the room also, that come to your office and they have this knee and they say, well, my primary care physician said I need a simple arthroscopy and it's going to cure all my medial-sided pain. It doesn't quite work that way. So these are the things you got to get comfortable with. Graft selection, I think the most important part of this is ultimately you are the patient's tissue banker. Just same thing with knee allograft surgery. So you got to get comfortable with a tissue bank who is certified by the American Association of Tissue Banks and develop a method with them for sizing their allograft. I think this is a relatively common procedure now. I think when I was a fellow in Pittsburgh in 92, we did the first one there. So this has been around for a while, and you can do these very easily with your tissue banker, so there should not be any problem with this. Most of the grafts today are fresh frozen. CryoLife used to be around making grafts, but this is how the graft comes to you. So this is a medial meniscus allograft that we're going to prepare using plugs. Very easy to work with. You still have problems sometimes, at least I do, getting the appropriate size allograft, depending on who you're putting in. Obviously, size is important, but if you're going to do a medial or lateral side, obviously you need to work closely with your tissue bank. What about the meniscal allograft and the preparation of? I think most of us agree that having bone plugs for the meniscal root attachment to preserve those circumferential fibers that Nick talked about is critical. There's been a few studies that have looked at this, and I think it maintains hoop stress transfer. Your meniscus is anchored at the roots, which sees a lot of load, and I think most of us appreciate bone-to-bone healing as opposed to soft tissue in a bone tunnel. What about the surgical technique for this? The way I do this is an arthroscopically assisted technique. I always have a 30 and a 70-degree arthroscope in the room, prepped, ready to go, just like I'm doing posterior cruciate ligament surgery. Because if I got to look in the back of the knee, I want a 70-degree arthroscope. It helps me see better, and For me, in an academic environment, working with residents and fellows, it's nice when I can see, or particularly they can see. If they can't see, they tend to do scary things sometimes. Decreased morbidity, we can see. It is technically demanding, and you just got to pick how you're going to do this, whether it be drills with bone plugs or a slot technique. As I mentioned, it is an arthroscopically assisted technique. I think what we've learned in shoulder surgery and recently has been a renowned focus on ACL surgery. Anatomic placement is critical. There have been some recent studies that have looked at this in meniscal allograft surgery, and they have shown if you miss the anatomic root site at all, you're going to have problems with your meniscus. Kind of make logical sense, but I don't think, we as sports medicine surgeons, we somehow get away with non-anatomic surgery a little bit, whereas when we talk to our fracture surgeons who do pelvis surgery, if they miss the pelvis reduction by 2 millimeters, it's a difference of having a total hip and you doing well. If we were that critical on ourselves doing ACL surgery, 2 millimeters, wow, that'd be concerning. So you need to be anatomic and you need to be exactly where you want to be. So on the medial side, I drill bone tunnels. The back tunnel is obviously the most difficult one and the hardest to get to. So what you're looking at here is the scope is now in your posterior medial portal. So the scope, that same portal you make when you do PCL surgery. Here's your posterior cruciate ligament inserting on the tibia. Here's my gold guide coming through, and we know from cadaver studies the posterior horn of the medial meniscus inserts directly in front of the posterior cruciate ligament. So very easy for me to get there. I'm used to doing that and doing complex knee ligament surgery, so not so bad. On the lateral side, I think this is a little bit of an easier operation. You can do a slot or a keyhole technique. The horn sites are only a centimeter apart. The only thing you have to be a little bit careful of is going posterior, right? Because the neurovascular bundle lives directly behind the posterior horn of the lateral meniscus. So if you go straight back and you're going to get into trouble, it is going to be here on the lateral side. And this spot right here, as you're going backwards, you want to make sure the neurovascular bundle lives back here, so you got to be careful going back there. If you don't go far enough because you're gun shy, then your lateral meniscus is not going to be in far enough, and you're going to get recurrent bucket handle tears of your posterior horn of your lateral meniscus. I have had a patient referred to me for that where the previous surgeon was not far posterior enough, because I would imagine a little gun shy being back. So if you're not sure, bring a mini C-arm in the room and check it radiographically. Almost all ORs now have a mini C-arm in place to do that. You must be comfortable with meniscal fixation. I do a lot of cruciate ligaments, so I'm a meniscal, I repair a lot of menisci. I'm a suture-only person. I never got into the fixator mode. I do use proprietary devices as well as inside-out, but placing inside-out sutures through the stuff that Nick showed, you need to do in this operation, and getting the meniscus to heal to the periphery, really not a problem. It's amazing how quick it actually heals. As I mentioned, you need to provide secure horns. I'm a bone plug person, and I like bones on all my meniscal allografts. So here's a prepared meniscus on the back table of a lateral meniscus. You can see how close these horns are in attachment, and you use a slot or a keyhole technique. Here's the other menisci on the medial side with bone plugs on each one. Rehab, if you're doing a concomitant procedure, it's usually going to dictate this. I believe if you get firm fixation of both meniscal roots, you can move them very quickly, so moving them is not a problem, and then slowly go back to sports with time. Results, these are the results you need to look at, pain, and objectively you can look second look or arthroscopy. In general, pain relief is pretty good. Some of my happiest patients I've done this operation to, particularly on the lateral side. The lateral ones tend to do better, at least in my hands, and I have happier people in that subgroup. Indication is important. You need to do correct sizing, and graft choice is fresh frozen grafts. No clear evidence about technique when we look at our results of multiple studies. but I think most of us can appreciate how we like to have bone-to-bone healing and preserve our hoop stress transfer for those circumferential fibers. Rehab is variable. I think the biggest discussion is, when do they go back to sports? We're doing this in young people, so they are going back. I just tell them I don't like them to do that for 9 to 12 months. Now, do they listen? Of course they don't listen. We're talking about young patients who, when they leave the office, they pretty much do what they want to do. But at least what we tell them is make sure they don't. Complications that have been seen, these have all been reported. I think the biggest thing is posterior horn tears in the back, so that anatomic placement and fixation, particularly in the posterior aspect of the knee, is critical. Keys to success, as I mentioned at the beginning, is patient selection. We want to reproduce meniscal anatomy. Here's the anatomy is in the back of the knee on a cadaver specimen. So anterior cruciate ligament, posterior horn of the lateral meniscus, posterior horn of the medial meniscus directly in front of the posterior cruciate ligament. You can kind of see a slot technique on the lateral side, pretty easy, right? Look how close these are. If you're going to do a slot technique on the medial side, you got a long way to go, okay? And you got to be a little bit concerned of the posterior horn of the lateral meniscus. And look where your ACL attaches. Your ACL attaches is right here. So this, to me, is a little concerning on the medial side. So real quickly, I'll do a case presentation. This is a collegiate softball player, ACL reconstruction, outside surgeon, subtotal lateral meniscectomy. So this is the index ACL operation, okay? So at the time of primary ACL surgery, if I see this, I'm very concerned. To me, this is a drive-through sign. The posterolateral corner has been injured. I'm staring at the popliteus tendon. That's very, very bad. So this, to me, is unstable, this posterolateral side. So this was just cleaned up, ACL done. This is the ACL graft placed. So this is her examination at about 6 months out. ACL graft's abnormal. She's 6 months out. Her knee actually buckled in physical therapy trying to come back. So here's some MRI pictures of her ACL graft. Completely absent lateral meniscus, right? We've seen this picture earlier on the MRI talk. No posterior horn. We knew that from before, right? We were staring at the popliteus tendon. Some signal at the posterolateral corner I was concerned about. We're going to talk about anatomic ACL surgery later, but clearly non-anatomic ACL surgery. The ACL graft attaches right here on the femur, so easy to check that radiographically now. But she's got a lateral meniscus absent. So what did we do? Well, I just told this girl I need a year of her time. So she walks in the office. I say, if you're not willing to commit a year, then I can't help you. And they stare at you. They go, did he say year? How about that 4-month variety where I can be playing soccer in 4 months? I say, well, that's not me. You need to see somebody else. So took out her hardware, bone grafted her tunnels, and I started over. So we reconstructed her posterolateral corner. I also put in a lateral meniscus. So here's when I went in. So here's her lateral side. Okay, here's her graft. Here's her lateral meniscus. And I bone grafted this tunnel. And then 4.5 months later, I took her back. We reconstructed her ACL with a double bundle technique using an Achilles allograft, because I can get 2 grafts out of this graft. So I can think about the cost. Obviously, everybody thinks about that today. So here she is at the index revision surgery. Here's her lateral meniscus. I got to her early enough. Look at her articular cartilage, not so bad. Here's my 2 bundles from my graft, PL and AM. We shouldn't see a PL after we put in the AM. And so we revised her, and she did well with that. With that, I'll thank you very much. We'll go to the next speaker.